Canceritides of the female sexual organs, female cancer. Precancer cervical lesions, cervical intraepithelial neoplasia, erythroplakia with ATP, leukoplakia with ATP, adenomatosis. Risk factors for cervical intraepithelial lesions. Human papillomaviral infection is a common virus that most women will be infected with at the same time in their life. Smoking, multiple sexual partners, pregnancy before the age of 20, suffering from the conditions that affect the immune system, like human immunoviral conditions. Firstly, let us remind some facts from the anatomy. The vagina, as well as the vaginal part of the cervix, is covered by multi-layer squamous epithelium. And if we are talking about human papillomaviral infection as a risk factor for cervical intraepithelial neoplasia, it means that the upper layers of this epithelium is most common to be affected. But thanks to the squamation of this epithelium, this infection is disappeared in some period of time. That's why this infection belongs to the transition infection. Cervical intraepithelial neoplasia means atypical growing cells, which are present in this multi-layer epithelium or columnar epithelium. If we are talking about mild dysplasia, cervical intraepithelial neoplasia class 1, it means that abnormal atypical cells are present only in the 1/3 of the lining of the cervix. Cervical intraepithelial neoplasia second degree belong to the moderate dysplasia. It means abnormal cells can be found in 2/3 lining of the cervix. And cervical intraepithelial neoplasia class 3 means severe dysplasia. Abnormal cells can be found in more than 2/3 of the lining of the cervix and up to the full thickness of the lining. If we are talking about invasive cancer, it means that these atypical cells destroyed the basal layer into the depth 0.2 centimeters and entered to the bloodstream. What you need for making of the diagnosis cervical dysplasia? Firstly, assurance. You need to perform speculum examination. Traditionally, pap smear should be taken. Nowadays, it's more useful to recommend the woman to pass liquid-based cytology, in which you will obtain more positive morphological cells result. Visual inspection in speculum examination means processing of 3% acetic acid of a cervix and revealing a white spot. Colposcopy, imagination of the cervix under microscope. Cervical biopsy in affected areas, endocervical curettage. HPV testing is obligatory, and co-testing means Papa Nicolau smear and human papillomaviral testing. Traditionally, in Cusco speculum, the doctor should take the smear for oncocytological examination or pap smear. Pap means Papa Nicolau smear. It was the first scientist who firstly described these atypical changes in the columnar epithelium of the cervix. The smear should be taken from squamo-columnar junction. It's the border between multi-layer squamous epithelium and one-layer columnar epithelium of the cervix is the thinnest place in the female cervix. The more thinner place, the more affected by the unfavorable factors. And we are talking about human papillomaviral infection as a risk factor for cervical intraepithelial lesion. The smell should be taken from squamo-columnar junction, which is called as transition zone. Cells are scraped from the cervix and examined under a microscope to check for disease or other problems. For this, you need special brush, the glass or spatula. Such type of brush is better comparing with the previous one because the apex of this brush obtains the smells from the endocervix, and this part of the brush obtains the cells from the exocervix. Frequency of pap smears begin no later than age 21. If patient is sexually active before 21. Once initiated, screening should be performed annually. After 30 years old, for women who have had 3 consecutive normal pap smears, screening frequency may be reduced to every 3 years. And screening may stop after total hysterectomy in the woman more than 70 years old if the patient is at low risk and has had 3 consecutive normal pap smears within the last 10 years. There are 6 types of pap smears. The first one, normal type of smear. Second, A, inflammatory process. Second, B, hyperkeratosis, metaplasia. Third, A, mild dysplasia. Third, B, moderate dysplasia. Fourth one, severe in situ, carcinoma in situ or severe dysplasia. Cervical cancer, the first one, and the fifth and the sixth. Smear is not informative. Here you would observe the correspondence with different classification. Papa-Nicolau, dysplasia classification, Bethesda classification, and histological classification. According to Papa-Nicolau classification, as I have mentioned, we have 6 types of pap smear. And if it means Bethesda classification, which is based on the result of morphological examination in liquid-based cytology, you have negative intraepithelial lesions. Papa-Nicolau classification, the second class, means ASCUS or ASC-H. It means negative or squamous atypia. Set A classification corresponds with the mild cervical dysplasia, and it means low squamous intraepithelial lesions. Histologically, it means cervical intraepithelial neoplasia, the first degree. Set B means moderate dysplasia, belong to the high squamous intraepithelial lesions. Cervical intraepithelial neoplasia, second degree. The fourth one belong to the severe dysplasia, also high squamous intraepithelial lesions, corresponds with the third degree of the cervical intraepithelial neoplasia. And the fifth one means carcinoma of the cervix in all of the classification. If the patient is HPV positive, in all cases, colposcopy is indicated. Co-testing nowadays means HPV testing and Papa-Nicolau smear from the squamo-columnar junction. management of these different classes of dysplasia. Class first, if we are talking about the Papa Nicolaus smears, routine gynecological screening, which was mentioned below. Class second A, the doctor should prescribe appropriate anti-inflammatory treatment and repeat pap smear in 6 months. Class second B, the doctor prescribe also appropriate anti-inflammatory treatment, this hormonal treatment maybe, and repeat code testing 6 months later. Third A, prescription appropriate treatment according to the obtained changes, continuous monitoring with code testing 6-12 months later. Class third B, fourth, fifth one, undergo colposcopy, biopsy, endocervical curettage, cone biopsy, monitoring, and contesting 3, 6, 12 months. And if you obtain the 6th type of pap smear, it means you would repeat test as soon as possible. If we are talking about biopsy, we mean cone biopsy. A cone-shaped piece of tissue containing the abnormal cells is removed for confirmation of precancer or cancer origin of the cervical problem. As you have seen, in 70% of cases, the cervical intraepithelial neoplasia, the first degree, undergoes spontaneous regression. You should monitor for such patients. The patients don't need surgical intervention. You prescribe anti-inflammatory drugs according to the result of bacterioscopic smears. For example, if trichomoniasis were found in these patients, you prescribe metronidazole. In the case of the candidiasis, you prescribe some drugs which are against Candida albicans. In the case of the dyshormonal changes, you try to correct this hormonal disbalance. And in the cervical intraepithelial neoplasia second and third degree, the woman should undergo oncologist for confirmation, histological confirmation of this diagnosis, and these abnormal cells are removed by resection, which is performed by special electrosurgical excision procedure or called knife conization. Cancer of the cervix is the most common female genital cancer. In developing countries, every year about 500,000 women are affected, acquire the disease, and 75% are from frame developing countries. About 300,000 women also die from the disease annually, and of these, 75% are from the developing countries. What are the main risk factors for cervical carcinoma? Human papillomavirus infection, especially type 16, 18, 31, 33, 35, and 6 more. Family history of cancer. Age 35, 55. Sexual and reproductive history. Socioeconomic state. Smoking. Human immunoviral infection. For a long period present or in the uterus intrauterine device. Using of oral contraceptives. Pay attention, students. From initial infection to cervical intraepithelial neoplasia 3rd degree, you need 6 years. And 10 years from 3rd degree to cancer. It means that if the woman has cervical cancer, he have not visited a gynecology during 16 years. What are the main types of cervical cancer? They are squamous cell carcinoma. It is present in 80 to 90% of cancers. Cancer of the flat epithelial cells. Adenocarcinoma of the cervix. Cancer from glandular epithelium, present in 10 to 20% of cases. And mixed carcinoma, most often present of signs of both types. There are 4 stages of cervical carcinoma. The first one, second, third, and fourth. The higher stage, the more organs are involved in pathological process. On the first one, you have only involvement of the cervix. On the second one, involvement the more depths of the cervix and upper part of the vagina. On the third one, you have spreading of this process into the vagina and upper and lower part of the uterus. And in the fourth one, adjacent organs of the true pelvis are involved in this process. The main symptoms of cervical cancer: abnormal bleeding between periods, with intercourse, after menopause, unusual vaginal discharge, and some other symptoms as leg pain, pelvic pain, bleeding from the rectum of the bladder. But pay attention, some women have no symptoms. For diagnosis, you take into account complaints, family history of cancer, speculum examination, cytological examination, HPV screening, bimanual vaginal examination, rectovaginal examination, application of acetic acid and colposcopy, and finally biopsy. What should I do if I have just been diagnosed with cervical cancer? You should discuss that method of treatment options as conization, hysterectomy, radical trachelectomy, radical hysterectomy, combination radiation with chemotherapy. The woman undergo monitoring in the oncologist department. And other considerations: preserve your ovaries and preserve your fertility if you are a patient of reproductive age. In stage, the first one, you have 5-year survival, 81–96%. The second stage cervical cancer patients have 65–87% survival. Stage 3, 35–50% survival. And in the fourth A, 15–20% of survival. Nowadays, you should know about the vaccination in the adolescent by Cervarix or Gardasil for prevention of cervical cancer. Cervarix means human papillomaviral bivalent vaccine recombinant, and Gardasil is active against 4 types of human papillomaviral infection. Who should get the vaccine? Girls at the age 11–12, recommended age group, but can be started as earlier from the 9 years old. Women 16–26 years old. The benefit of the vaccine may be lower depending on prior HPV exposure. The vaccine doesn't work to eliminate current HPV infection, but the vaccination prevents certain types of HPV infection. You can prevent cervical cancer if you vaccinate early, pap test regularly, and HPV testing when recommended by a health care provider. Endometrial cancer precursors. Endometrial hyperplasia, this is the overgrowth of the lining of the uterus. This is the precursor to the development of cancer. Abnormal uterine bleeding is usually the first symptom of endometrial hyperplasia. And in a productive age patient, endometrial hyperplasia defines as thickness of endometrial lining more than 15-16 centimeters. In menopause, more than 4-5 millimeters. All of these endometrial hyperplastic changes accompanied with abnormal risk indicators for endometrial cancer and precursors. Age 60, obesity, estrogen-only replacement therapy, previous breast cancer, tamoxifen therapy for breast cancer, chronic liver disease, infertility, low fertility, chronic anovulation, polycystic ovarian disease, estrogen secretion ovarian stroma or tumors. Classification and diagnostic criteria of endometrial hyperplasia. Simple hyperplasia without cytological atypia. Increased number of glands relative to stroma. Dilated glands with irregular outlines. Crowded clustered glands. Tall columnar epithelium with nuclear pseudostratification. Complex hyperplasia without cytologic atypia. Increased number of glands relative to stroma. Back-to-back glands. Crowded glands with little or no interventing stroma. A hyperplasia with cytological atypia. Variation of size and shape of nucleus. Nuclear enlargement, loss of polarity, post-chromatin clumping, hyperchromatism, chromatin nucleus. All of these changes should be observed in histological examination. On the first page, you would observe the cystic hyperplasia. On the second one, simple hyperplasia. Atypical hyperplasia, the first one, and simple on the second. Confirmation of the diagnosis need to prescription of ultrasound and measurement of endometrial thickness is the main at ultrasound. As I have told, enlargement of the endometrial thickness more than 17 millimeters in reproductive age patient and more than 4 or 5 millimeters in the patient climacterial menopause suggests about endometrial hyperplasia. Firstly, what you should do for such patients all over the world, endometrial biopsy. For this, you need a special catheter which is inserted into the uterus through the vagina to remove cells from the uterine lining and for examination. You should confirm presence of these abnormal cells thanks to endometrial biopsy. In the Ukraine, most common for such patient dilation and curettage is recommended. For the treatment, the first after dilation and curettage, the first line treatment means prescription of the progesterone-containing pills for suppression of high level of the estrogens. For this, you would recommend intramuscular progesterone therapy, medroxyprogesterone acetate, 500 milligrams therapy for 3 months, micronized progesterone, cyclic natural macronized progesterone for 3 to 6 months, insertion of levonorgestrel intrauterine device, which is called as Mirena. On the first day of menstruation, the doctor inserted an intrauterine device which releases every day 20 microgram of levonorgestrel. It is more suitable, is not so expensive and comfortable for such patients. And finally, gonadotropin releasing hormone analogs for 6 months with sampling every 3 months is a reasonable option in patients without atopia. What are the main risk factors for uterine cancer? Early menarche, late menopause, overweight, never had kids, sporting or abnormal vaginal bleeding, and bladder infections. Here you would observe the uterine cancer. All layers of the endometrium, of the myometrium, is involved by this abnormal growing tumor. Staging of the uterine carcinoma, grade 1, according to histological grading system. Well-differentiated carcinoma consists of a neoplasm with less than 5% of solid cancer. Grade 2, moderate differentiated carcinoma contains between 6 and 50% solid cancer. Grade 3, poorly differentiated carcinoma is made up of more than 50% of solid tumor. Modified classification of the endometrial carcinoma. Endometrial adenocarcinoma, cirrhosis carcinoma, clear cells carcinoma, mucinosis carcinoma, cirrhosis carcinoma, mixed types of carcinoma, and undifferentiated carcinoma. There are 4 stages of endometrial carcinoma. In the first one, you have involvement of the endometrium, some parts of the myometrium. On the first one, the higher stage, the more involvement. And in this fourth one, you have involvement of the adjacent organs. Clinical signs: irregular vaginal bleeding, intermenstrual or postmenopausal. Watery vaginal discharge may be present in postmenopausal women and present of the mass in the late stages. What you need for investigation of the endometrial cancer: transvaginal sonographical investigation and biopsy, hysteroscopy and biopsy, computer scan or magnetic resonance imaging. All of these methods should confirm the presence of the endometrial carcinoma. At ultrasound, you will obtain the enlargement or thickness of endometrium lining. For confirmation, you need biopsy, and during pipal biopsy, you would obtain these cells from the uterine cavity, which should be sent to histological examination. Treatment: operative total abdominal hysterectomy and bilateral salpingo-oophorectomy, plus minus lymph node dissection in the operation is the choice. Adjuvant radiotherapy for the grades, for the stages more than first B. Chemotherapy in the endometrial cancer is ineffective. Hormonal therapy in some cases is indicated in reproductive age patients. You will start from progesterones in early or recurrent cases. 5-year survival rate for endometrial cancer. In the first A degree stage, 91% survival is present. The higher degree, the higher stage, the less percent of 5-year survival. And as you see in the stage 4, you have 17% of cases survival. Ovarian cancer is the second most common gynecological malignancy. The most frequent cause of death from gynecological cancers, due to advanced stage at the time of diagnosis. 53% of all deaths from gynecological cancers. Incidence increases with age, most marked beyond 50 years old, with increase continuing to age 70 and decrease after age 80. Risk factors: family history of cancer, personal history of cancer. Women who have had cancer of the breast, uterus, colon, or rectum have a higher risk of ovarian cancer. Age over 55, never pregnant, menopausal hormone therapy like estrogen taking. That's why nowadays, if you would recommend the patient to take estrogen in the menopause, you try to suppress this estrogen by progesterone prescription. Classification of ovarian cancer: primary, neoplasm derived from the ovarian surface epithelium. Secondary, neoplasm derived from papillary or pseudomucinosis cyst adenomas. And metastatic, intestinal and breast metastasis. Classification of ovarian cancer: surface epithelial, ovarian cancer is present in 65–70% of cases. Cirrhosis, adenomas, mucinous, endometrioid, transitional cells as Brenner's, clear cells. Stroma in 15–20% of cases. Granulosa cell tumor, tecoma, fibroma, Sertoli-Leydig cell tumors. The third one, germ cell tumors in 5–10% of cases. Teratoma, benign cystic dermoid cyst, solid immature cyst. Monodermal, like ovarian stroma, carcinoid. Dysherminoma, yolk cell tumor, choriocarcinoma, mixed germ cell tumor, and metastatic tumors. In the picture you would observe the cirrhosis cyst adenoma large sizes, serous. Papillary cirrhosis cyst adenoma, like borderline. Pay attention to the internal surface of this capsula, which is filled by abnormal papillary growings, which suggest presence of cancer. Papillary cyst adenoma. Ovarian tecoma, students, it is solid tumor with variegated yellow-orange appearance. Produces estrogens. Metastatic Krukenberg tumor. It means involvement of the stomach. Primary origin of the cancer is stomach. And secondly, ovaries are involved in the pathological process. Classification of the ovarian cancer. There are also 4 stages of ovarian cancer. In the first one, most common ovaries both are involved. On the second stage, involvement of the uterus, fallopian tube, other pelvic organs are present. And the third one, you have peritoneal involvement. And in the fourth stage, you have distant metastasis. Silent killer is most typical for ovarian cancer. It means, what are the main clinical signs of the ovarian cancer? They are bloating, pelvic or abdominal pain, pain in the back or legs, diarrhea, gas, nausea, constipation, indigestion, difficulty eating or feeling full weakly, urinary symptoms, pain during sex, abnormal vaginal bleeding, trouble breathing. The picture you would observe the patient with the ascites as a result of the ovarian cancer, enlargement of the abdomen, dyspnea, presence of the fundus in the true pelvis. Diagnosis means physical examination, pelvic examination in which you revealed the pelvic mass by rigid or irregular contours, large sizes. Rectovaginal examination would reveal the metastatic involvement of the posterior cul-de-sac and presence of the tumor in the true pelvis. Ultrasound revealed the tumor. Magnetic resonance imaging will confirm presence of the tumor and local and distal metastasis. Cancer 100 antigen 125 high false positive rate is more better to recommend HE4 marker, which is more sensitive this cancer antigen 125. And finally, laparoscopic investigation. The combination of HE4 and cancer antigen 125 was more sensitive than either marker alone. Risk of ovarian malignancy algorithm index Roma is calculated. And ovarian cancer treatment nowadays, in most commonly you would prefer surgery. Combination of the chemotherapy with surgical intervention is more useful. Chemotherapy alone will give you less positive results. And surgical chemotherapy and radiation also is recommended. The 5-year survival rate for all stages of ovarian cancer is 45%. For cases where a diagnosis is made early in the disease, when the cancer is still confined to the primary site, the 5-year survival rate is 92%. And nowadays, it is better to prevent cancer of the female sexual organs. For this, eat healthy, be active, be screened, be a healthy weight, be smoke-free, and limit alcohol.
Hi everyone, this lesson is on the signs and symptoms of endometrial cancer. If you want more information on endometrial cancer, including risk factors, pathogenesis, how it's diagnosed and treated, please check out my full lesson on this topic. Before we get into the signs and symptoms, let's talk about what endometrial cancer is. So endometrial cancer is also known as corpus cancer. It is a cancer of the endometrium, and the endometrium is the inner lining of the uterus. And endometrial cancer is going to be malignant cells of glands of the endometrium. Now, there are a large list of risk factors for getting endometrial cancer, and most of them are related to increased estrogen levels. So, either abnormally high estrogen levels, unopposed estrogen, meaning that there is no progesterone opposing the estrogen, or long periods of exposure to estrogen. Again, if you want more information on those risk factors, please check out my full lesson on this topic. Endometrial cancer is actually the most common gynecological cancer. Females have a lifetime risk of 2 to 3% for getting this type of cancer, and the mean age of onset is 62 years old. Now, the topic of this lesson is the signs and symptoms of endometrial cancer, and endometrial cancer does cause a variety of signs and symptoms, and we're going to talk about those signs and symptoms and why they occur in the upcoming slides. So by far the most important sign of endometrial cancer is abnormal uterine bleeding. This is again going to be the most important and common sign. Now, I didn't talk about this before, but there are actually two types of endometrial cancer. There's type 1 and type 2. Again, if you want more information, please check out my full lesson on this topic. But by far, the majority of cases are type 1, and this is going to be the common and most important sign in type 1 endometrial cancer, that abnormal uterine bleeding. It is a painless bleeding. There is no pain associated with the bleeding. And you can imagine that it is going to be due to erosions and or tissue growth from the cancer in the endometrium. So as the cancer grows in the endometrium, it starts to gather up blood supply and can bleed. And that can be seen as abnormal uterine or abnormal vaginal bleeding. Now, there are three subsets of patient populations that it's important to recognize abnormal uterine bleeding in. One is going to be premenopausal patients. Another group is perimenopausal patients, and the third group is postmenopausal patients. So in premenopausal patients, or patients who have not undergone menopause or are not close to menopause, abnormal uterine bleeding is going to appear as heavy menstrual bleeding or menorrhagia. So if a patient has a normal menstrual cycle and they start to have heavier menstrual bleeding than usual, so that would be menorrhagia, that could be a sign of endometrial cancer, although there are many other causes of menorrhagia. And then another potential sign that can be seen in premenopausal patients is intermenstrual bleeding or intermenstrual spotting. So these are going to be more vague findings in these patients. But what's going to be more important is in the other two groups of patients, because majority of patients who have endometrial cancer are going to be postmenopausal and perimenopausal. So premenopausal patients are less common, and a lot of the signs of the disease can be more vague and nonspecific, so they can be more difficult to detect. In perimenopausal patients, what should happen is that as a patient starts to undergo or get close to menopause, their periods or their menstruation should decrease in severity and become less and less frequent over time as they get closer and closer to menopause. So if they start to have that pattern where they have decreasing frequency and decreasing severity of menstrual bleeding, so their menstrual cycles start to taper off, and then all of a sudden it starts to increase in frequency and severity of menstrual bleeding again, that is a sign of endometrial cancer. That is abnormal uterine or abnormal vaginal bleeding. So that is something that should be investigated in patients who are experiencing that. Again, in the perimenopausal period, as a patient gets closer to menopause, their periods should get less and less frequent and less severe. So their menstrual bleeding should start to taper off as they get closer to menopause. If they have that pattern where they are getting closer and closer to menopause, their periods are tapering off, becoming less frequent, less severe, and then all of a sudden it starts to increase in frequency and increase in severity of the bleeding with each menstrual cycle or each period, that is a potential sign of endometrial cancer. So that, again, that is something that should be investigated. And then in the third group of patients, these are going to be the majority of patients. So postmenopausal patients, 75% of patients who have endometrial cancer are going to be postmenopausal. So this is going to be the major group of individuals who are going to get endometrial cancer. And in this group of patients, any postmenopausal bleeding is abnormal. So that is going to be the finding in patients who have endometrial cancer, although many other things can cause abnormal uterine bleeding in all of these groups, including uterine polyps, for instance. So again, abnormal uterine bleeding doesn't necessarily mean that a patient has endometrial cancer, but it should be something that is investigated, especially in perimenopausal and postmenopausal patients. Some other signs and symptoms of endometrial cancer include abdominal pain. So this is going to be a pain or discomfort, and it can be generalized or a focal pain. And it's due to cancer extension into surrounding areas. You can imagine that as the cancer starts to grow into the endometrium and starts to spread beyond the uterus, this can lead to pain from that extension into particular areas in the abdominal cavity. And this abdominal pain is going to be more likely to occur in type 2 endometrial cancer, whereas the abnormal uterine bleeding is going to be more common in type 1. And then another possible sign or symptom of endometrial cancer is bloating. So again, abdominal bloating, and this is going to be more likely to occur in type 2 endometrial cancer. So abdominal pain and bloating can be symptoms of type 2 endometrial cancer, but a lot of times these symptoms are not going to help because they are very vague. So they're non-specific findings. Many conditions can cause these types of issues. So again, these are going to be more likely to occur in type 2 endometrial cancer. Pelvic pressure is also another finding in endometrial cancer. This could be pelvic pain or pelvic discomfort. This is also due to extension of the cancer. And again, this is more likely to occur in type 2 endometrial cancer. And some patients may have a pelvic mass as well. So abdominal pain, bloating, and pelvic pressure could be found in type 2 endometrial cancer more commonly than in type 1, where abnormal uterine bleeding would be more common. Dyspareunia is also another potential symptom in patients who have endometrial cancer. Dyspareunia is pain during sexual intercourse, and dyspareunia may occur with endometrial cancer, but it depends on the location of the cancer in the endometrium. If the cancer is closer to the cervix, it may be more noticeable to the patient. And then due to the excessive bleeding from abnormal uterine bleeding, in especially type 1 endometrial cancer, there can be some complications of the excessive bleeding. This excessive bleeding, especially if it's left for long periods of time, can lead to iron deficiency anemia, and iron deficiency anemia can present with its own signs and symptoms. So again, that excessive and or prolonged abnormal uterine or abnormal vaginal bleeding can lead to iron deficiency anemia. And signs and symptoms of iron deficiency anemia include fatigue, weakness, decreased concentration, presyncope, syncope, so dizziness or fainting. And there can be some other particular signs and symptoms of iron deficiency anemia, including koilonychia or spoon-shaped nails. There can be angular cheilitis, so cracking around the lips. So there are other signs and symptoms that can occur, especially if there is long-term excessive bleeding from endometrial cancer. If you want to learn more about endometrial cancer, please check out my full lesson on that topic. And if you haven't already, please like and subscribe for more lessons like this one. Thank you so much for watching, and hope to see you next time. Hi everyone, this lesson is on the signs and symptoms of cervical cancer. If you want more information on cervical cancer, please check out my full lesson on that topic. Before we get into the signs and symptoms, let's talk about what cervical cancer is. Cervical cancer is cancer of the cervix, and the cervix is actually the lower end of the uterus at the junction of the vagina. So here is the cervix, and you can see that there is a cancer growing here, and it can spread into surrounding structures, leading to particular signs and symptoms and other findings we're going to talk about later on in this lesson. Cervical cancer is caused by human papillomavirus, or HPV, and there are specific types of HPV that increase the risk of getting cervical cancer. If you want more information, again, please check out my full lesson on that topic. And the risk factors for getting cervical cancer are related to risk factors for getting HPV. Again, please check out my full lesson for more information. Now, cervical cancer is a very common type of cancer. It's actually the third to fourth most common gynecological cancer worldwide, although it is more prevalent in developing countries compared to developed countries. The average age of onset of this cancer is 52 years old, and there has been declining rates of this type of cancer over the past few decades due to increased screening programs with pap smears. So again, for more information, please check out my full lesson on this topic. But the topic of this lesson is the signs and symptoms. And in fact, cervical cancer can cause a variety of signs and symptoms, and we're going to talk about those signs and symptoms and why they occur in the next upcoming slides. Now let's talk about the signs and symptoms of cervical cancer. Before we actually get into the signs and symptoms, it's important to note that many cases of cervical cancer are going to be detected with screening methods like pap smear and colposcopy. So a lot of times patients may have a very early stage of cervical cancer, but they may have no symptoms at all, which means that they would be asymptomatic. So some cases of cervical cancer can be asymptomatic, meaning that they have no symptoms at all. But if they do have signs and symptoms, the most important finding or the most important sign of cervical cancer, and oftentimes the first sign of cervical cancer, is abnormal vaginal bleeding. So abnormal vaginal bleeding is, again, one of the most common and early signs of cervical cancer, if not the first sign. It often starts with postcoital bleeding, meaning that after intercourse, the patient will experience vaginal bleeding. So this is oftentimes going to be the first time patients will notice this abnormal vaginal bleeding. Over time, though, this abnormal vaginal bleeding will become more frequent and spontaneous as the disease progresses. This will show up as heavy menstrual bleeding. So menstrual bleeding, where a patient's period will become heavier. They may also have intermenstrual bleeding, meaning that there is bleeding, spotting, or heavier bleeding between periods. Or if a woman is postmenopausal, if they have postmenopausal bleeding, that is going to be abnormal vaginal bleeding as well. So you can imagine the reason why this occurs is that if there is a growing cancer on the cervix can become eroded, ulcerated from the cancer, and cause bleeding to be found in. Another important finding in cervical cancer is vaginal discharge. So vaginal discharge is, again, one of the first signs of cervical cancer. It's often, again, going to be found early on in the disease course. What will be noted is that the vaginal discharge will often start out as watery discharge and then will later on become more red to brown in coloration. It can also become malodorous, meaning that it can smell or have a funny smell to it. And it's due to the inflammatory process that is going on within the cervix due to the growing cancer. So this is also an important finding with cervical cancer as well. Other important symptoms of cervical cancer include vaginal discomfort. So vaginal discomfort is going to be either pain, discomfort, or irritation. This can be found with pain during intercourse as well, so this would be known as dyspareunia. So this can be a finding of cervical cancer. So if there's dyspareunia and then postcoital bleeding, this can be findings in cervical cancer. And you can imagine the reason why this occurs is because the cancer starts to spread. It starts to extend past the cervix into the vagina, and this can lead to pain, irritation, and discomfort. Pelvic pain can also be another finding in cervical cancer. This is going to be an unexplained pelvic pain. So if there's another explanation, that doesn't mean that the pelvic pain is due to cervical cancer. So this is oftentimes going to be an unexplained pelvic pain. And this is going to be due to the cancer spreading into the surrounding areas, impinging on local nerves. So again, that cancer starts to extend out past the cervix and enter into the pelvic wall and impinge on some of the surrounding structures in the pelvis. Cervical cancer patients can also have back pain. So as the cancer spreads and it increases in size, it starts to extend into other areas. There can be unexplained back pain. So again, it's going to be unexplained. So it's not going to be due to some musculoskeletal injury. It's going to be an unexplained back pain. And again, this is going to be due to the cancer extending into or past the true pelvis. Dysuria is also another finding in cervical cancer in some patients. So a lot of these findings we're going to talk about are going to be in later stages of the disease when the cancer has spread. So dysuria is a burning sensation while urinating. So this burning sensation while urinating is going to be or could be due to the cancer impinging on the bladder itself or on the urethra. So if there's something pushing on the bladder or the urethra, and when an individual urinates, there can be some burning from that impingement. So again, these findings, including back pain and dysuria, are going to be findings that occur later on in the disease, so in later stages of the disease. So most commonly, a patient will experience abnormal vaginal bleeding and vaginal discharge before they have some of these other findings, including back pain and dysuria, and the other findings we're going to talk about here in a moment. And some of those include urinary retention. So urinary retention is a difficulty initiating urination, disrupted urine stream, or a complete inability to urinate. So a patient feels that they have to urinate, they try, but there's some difficulty initiating urination. Or when they get started, there's some disruption of the urine stream, it's not a steady stream, or there's a complete inability to urinate at all. So a patient may be completely obstructed in their ability to urinate. So that would be complete urinary retention. And this is due to the cancer compressing surrounding structures, including the urethra. So we talked about dysuria being a case where the cancer may be compressing the urethra, but in the case of urinary retention, this may be a complete compression of the urethra. So the patient may not be able to urinate at all. Constipation can also occur in patients with cervical cancer in later stages of the disease. So constipation is going to be reduced frequency of defecation or increased consistency of stool. And patients may also have obstipation, meaning that they don't pass any flatus at all. And this would be due to a bowel obstruction. So as the cervical cancer grows and extends and starts to compress on the large intestine, this can cause constipation and in some cases may even lead to a bowel obstruction, so lead to the patient having obstipation. Now there are some other complications of metastasis of the cervical cancer. A lot of the previous findings we talked about are going to be due to increased extension of the cervical cancer into surrounding areas, but there can be even more extension into particular areas that lead to particular findings, and these include the following. Leg edema. So leg edema is a swelling of the legs due to accumulation of interstitial fluid. So there's increased fluid in the interstitial area. So what's supposed to happen is that the fluid in the interstitial area is supposed to be drained by the lymphatics. But if there is a growing cancer in the pelvis, this can lead to compression on lymphatic drainage in the pelvis, meaning that the flow of lymph or drainage of the fluid is impeded. So this can lead to a buildup of fluid in the legs. So this can lead to leg edema. We can also see pain, and this is going to again be back pain we talked about before. And we can also see hydronephrosis. Hydronephrosis is going to be a condition where there is fluid buildup around the kidney. And this condition of hydronephrosis is going to be due to compression on urinary outflow or urinary retention. So if the cancer from the cervix begins to compress on one of the ureters, this can lead to compression of the ureter and lead to a hydroureter. So the kidney will continue to make urine, but if there's a compression on one of the ureters, that urine cannot pass that obstruction, leading to a backup of the urine in the ureter, leading to hydroureter, and eventually that urine will back up into the kidney itself, leading to hydronephrosis. In the case where the cervical cancer actually impinges or completely compresses the urethra, leading to urinary retention, this can lead to a patient having a full bladder. They're not able to urinate. If they're not able to actually clear that obstruction, their kidneys again continue to make urine. So both kidneys will continue to make urine, but if they have nowhere to go, if that urine has nowhere to go, the urine starts to back up into the ureters again, causing hydroureters on both sides, and bilaterally, and lead to fluid accumulation, or that urine being accumulated in the kidney, leading to hydronephrosis bilaterally. So those are two ways that hydronephrosis can occur in cervical cancer. All three of these findings are a triad indicating pelvic wall involvement. So this is something that can be helpful in determining pelvic wall involvement. If you see leg edema, back pain, and hydronephrosis, these are a triad indicating pelvic wall involvement. And the next signs are going to be signs that are noted when a clinician actually visibly looks at or examines the cervix. So there are visible abnormalities on the cervix that can be found in patients with cervical cancer because there is a cancer that is going to be growing on the cervix. So oftentimes what can be noted is that the cervix itself can be friable, can have redness, and there can be some ulcerations. So these are some key words or findings or descriptions of a cervix that has a cancerous growth or cancer tissue developing on it. So this would be something that a physician or a clinician may see when they are examining the cervix. But again, not all cases of cervical cancer will have these visible abnormalities. There may be a very early case that is detected by pap smear, so there would be a case of cervical cancer that shows no abnormality. So again, that can also be important because a lot of times there may be no symptoms, so asymptomatic, but there may also be no signs on the cervix as well, especially if detected early on with pap smear. If you want to learn more about cervical cancer, please check my full lesson on this topic. And if you haven't already, please like and subscribe for more lessons like this one. Thanks so much for watching, and hope to see you next time.